At the outset, let me thank Abu and I was given Panchi. I mean, we talk about so the topic that you give me is I mean related to compliance, and we talk about regular intake. Thing. What do I do? Given the favorite cream part of it to the favorite boy, Dr. Praveen, the crumbs to me. So how do I defend? Then I looked at the topic again. Keyword is ever, justify. And I would say, let's see what things are in store. Why is this debate clinically relevant? We have the GLP-1 receptor agonist and dual incretin therapies, which are increasing for years or decades in routine practice. The annual financial burden, as we know, of these financial and public health systems under the real world adherence steadily declines after the first year despite excellent trials. Long term safety data beyond 1 decade and income. Many patients report psychological questioning uninterrupted over practical. We are also accosted with spurious and falsified versions, and the WHO fully recognizes this. Now, the concept of drug holiday has been very well recognized by the obesity medicine and also the other relevant agency recommendations of whom we follow. And common side effects of drugs of the GLP-1 receptor agonist categories, we all know nausea, vomiting, diarrhea, etc. Gastroesophageal reflux can often be managed by slowing down the dose titration, and therein comes the concept of potential drug de-escalation, dose de-escalation, or drug holiday, as and when the situations may arise. Now, obesity is very correctly classified as a chronic disease that requires long-term management, but this classification has been automatically translated into belief that the medication must be continuous for life. Now, this assumption was borrowed from other chronic diseases like hypertension and diabetes, etc. Body weight is governed by adaptive neuroendocrine feedback loops rather than a single linear parameter. This is what we have to remember. And the continuous pharmacologic pressure may provoke biologic counter responses and tolerance. So, the equivalence between chronic disease and continuous therapy deserves a critical reappraisal and a re-examination. How do we define a drug holiday? It's a deliberate, physician supervised, and time limited pause in pharmacotherapy, scheduled with clearly defined start dates, monitoring plans, and a very well defined restart criteria. Monitoring continuously active during the pause rather than stopping care. So you have to monitor and give the best possible benefit to the patient. Intent is optimization of efficacy and reduction of cumulative exposure. This approach, mind you, is protocol driven, not reactive. It's not like that the patient just goes off, which is non-compliance, and I'll allude to that point during the course of my presentation. And this must be distinguished from non-adherence or therapeutic failure. When defined this way, it is not abandonment of chronic disease care, it is adaptive pharmacotherapy that prioritizes safety, patient values, and long-term adherence. So modern obesity frameworks explicitly emphasize individualized dynamic treatment pathways rather than one dose forever kind of a. Now we know that the body weight is defended physiologically by hypothalamic circuitry that defends the adiposity within a very narrow biological range. There are signals of leptin, insulin, GLP-1, neuropeptide YY, ghrelin, etc. Weight loss is interpreted as a threat to survival. So that is why when you see that very many people who are uh, trying out diet modifications, beyond the point they are unable to basically lose weight because the body takes that as a kind of a threat to survival and kind of closets its hunger increases through neuropeptide Y and agouti related peptide activation. Resting energy expenditure declines beyond prediction. These responses collectively create a strong response. Now, this is physiological part of it. So what is the core proposition of my talk? That continuous therapy is not automatically synonymous with optimal therapy. Chronic receptor stimulation frequently leads to reduced sensitivity and pharmacological tolerance and tachyphylaxis. Periodic withdrawal may restore receptor responsiveness and preserve effectiveness. Patients often demonstrate better psychological engagement with you. Financial stability, sustainability improves, and a structured cyclic use may represent smarter and more durable medicine. What is the set point theory? Each individual seems to have a biological defended weight. Attempts to go beyond this threshold activates the counter-regulatory hormonal changes. So pharmacotherapy, like the GLP-1 receptor agonist, temporarily suppresses these diseases and facilitates loss. And constant pharmacological override may not permanently recalibrate this system. And stabilization periods may allow for consolidation of a lower dependent weight. Now, metabolic adaptation is quantifiable and persistent. This phenomenon, the resting metabolic rate drops disproportionately after weight reduction compared with predicted value, which is called as adaptive thermogenesis. And the reduction may reach 10 to 15% beyond expected energy needs. Hormone signals favoring hunger persist long after weight loss, and very importantly, at times, escalating drug dose alone cannot permanently overcome this biology. So I'll just quickly skip over these slides because this has been dealt in detail. These are the mechanistic basis of the actions of one receptor agonist. But what are the consequences of continuous receptor stimulation? Prolonged agonist exposure induces receptor desensitization at the cellular level. And you have seen this, that beyond the point when you're giving these drugs, after the initial period, the effect kind of seems to plateau. Expectation of weight loss often does not match what we are trying to look at various. Now, the similar tolerance is well documented in the other G protein CR systems. Patients may reduce, sorry, given 15 minutes plus. I was given, huh? I have to skip through some things. Okay, let me see. Patients may report reduced appetite suppression over time, and dose escalation become necessary to maintain, effects, and the cost increase. Uh, I'll skip this reasons because I thought I had been given 15 minutes. That's what my mail said. So, interpreting the withdrawal data more carefully, abrupt stopping of a dose of a drug without tapering exaggerates the physiological rebound. And in these cases, monitoring was insufficient for early restart. The regain reflects unstructured withdrawal rather than proof against intermittent therapy. Mind you, no randomized trials have been tested planning cyclic protocols. Is that a marketing strategy? We don't know. An evidence gap should stimulate research rather than rigid conclusions. I'll skip this. Uh, uh, Drug holidays and pulsatile therapies are extremely well adapted situations in other drug therapies, other specialties. We know about biphosphonate holidays, corticosteroid tapering, fertility treatments, oncology protocols, neurology, etc. So this is something that the body knows and is adjusted to in the other specialties that we are looking. So, quickly speaking out here to drug holidays already happen. People may be opting out. The only question is whether we can make them safer and more beneficial for the patient. The reality of treatment fatigue is extremely well known. Weekly injections create a psychological burden. Financial strains are there. Patients often do not disclose non-adherence, and structured breaks may preserve honesty and engagement. Psychological benefits, drug-free intervals encourage patients to rely on behavioral skills, confidence in self-management improves, their dependency mindset decreases, patients experience greater autonomy, shared decision-making becomes more collaborative. So the risk must also be acknowledged. Weight gain can reoccur. That is why monitoring is a must. Glycemic control may deteriorate. Appetite may transiently decrease. Some patients experience anxiety. Not all individuals are appropriate candidates. Sorry. And careful selection and close monitoring are essential. These are the situations where the holiday should not be attempted. People who are in the active phase, weight loss, severe obesity, and high severe cardiovascular risk, poor adherence to lifestyle modification, uncontrolled diabetes, history of rapid rebound, earlier history does that. inability to attend regular follow-up visits, and some who are psychologically unstable. This is a protocol-driven drug holiday in which the indication, monitoring part, and the definitive exit criteria has been given. It's a disciplined obesity medicine. These are the ideal candidates for a drug holiday, people who have achieved at least 10 to 15% sustained weight loss. This is an option from which the patient has to be forthcoming, and then only it has to be basically implemented. Weight stable for several months, consistent dietary discipline, comfortable with self-monitoring, understands the potential need for restart, and engages in shared decision making. Now, quickly going on to three, four conditions in which drug holiday is paramount. We're looking at a patient pre-anesthetically when gastric aspiration can happen. So you have to stop the GLP-1, which is a structured drug holiday situation that we have. Secondly, in pregnancy planning, we know these are not indicated during pregnancy. Also in adolescence, we have to basically monitor very well because there can be scenarios of severe adverse effects, disordered eating risk, or psychosocial destabilization. People can often become anorexic, so we have to see that. And in people who have been losing mass, if the sarcopenia is paramount, so obviously you would prefer to give a drug holiday, maintain the, the protein training, resistance training, protein intake, and functional rehabilitation before the scheduling. So these are the criteria for reintroducing therapy. We address the common counter arguments saying that chronic disease status does not logically require continuous medication. Regain risk can be mitigated with structured monitoring. Planned holidays are supervised and safe. Economic realities often demand flexible strategies, and scientific progress requires testing alternatives. Uh, so, obesity biology is adaptive and resistant to constant pharmacological pressure. Continuous stimulation may diminish effectiveness over time. Cumulative safety exposure deserves caution, and a structured cyclic therapy addresses these limitations simultaneously. So intermittent therapy, therefore, often represents rational evolution of care. These are my take-home messages. And what I want to say that at no point am I, uh, you know, uh, 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 saying that the science of GLP therapy should not be compliant from the patient's perspective or continuous, but there exist certain situations in which drug holidays may be implemented in a consultation with the patients to give the optimal and the best possible results and best possible outcome. Thank you very much, and I think I'll rest my case here, then take it forward, Dr. Praveen, too.